So thank you so much for the invitation. Of course, all thanks to Dr. Bansi sir and the entire team of Diabetes India. I'm here today to talk about something a little off topic. We've all come to terms with the fact that CGM has become an integral part of the management of diabetes. And what we're going to be discussing in the next couple of minutes is the limitations that we have, and we need to accept and come to terms with the fact that yes, there are limitations, but how do we yet use it as a useful tool in our daily practice? So, is the slide isn't changing there? It's changing here. Yeah, okay, got it. Thank you. So, as we all know, CGM, like I said earlier, has become a widely used tool. And this is a slide that is going to show us, that is actually showing us the epidemiological data, that is to look at the use of CGM and the rise in percentage of use year-wise and the age groups as well. So as you can see, from 2011, from a mere 6%, the percentage of use has now grown to around 40%. I'm sure that now this is up to 2018, but I'm sure now if you look at current data, the use has probably risen even higher. And the age group, interestingly, as you can see, is more used in the younger age group, so probably in the pediatric population, children with type 1, and in the older age group above the age of 50 is where 25 or 30 to 50 is where, understandably so, because the older age group and the younger is where the use is also more probably more relevant. We've also come to terms with, I mean, I think it's pretty safe to say that CGM has now become an integral part beyond the HbA1c. We've moved past just treating patients with fasting postprandial and the HbA1c, but we've also realized now that HbA1c alone does not tell us about glucose variability or glucose fluctuations, in other words. So if a patient, say, has frequent episodes of hypoglycemia or frequent high fluctuations in the blood glucose, that patient could have the same HbA1c as a patient who has very smooth, narrow range of blood glucose. So on the left, you're seeing two patients in whom the HbA1c is 7.7, but as you can see, the narrow range. Which one is the pointer? Is it this? Yeah. So you're seeing two, scenarios in which the HbA1c is almost the same, is the same, but you're seeing here is a narrow range of blood glucose, whereas here you're seeing a lot of wide fluctuations. But at the end of the day, your HbA1c is going to be the same. So in other words, when we see patients in the clinic, HbA1c alone is not going to tell us about the glucose variability or the glycemic variability. And we also know now that time in range, there's a lot of light thrown recently, or discussions around this area, the TAR, TIR, and the TBR. We know that keeping the time in range to the maximum is key to also reducing the risk of complications. And we all know what time in range is. It's the percentage of time that the person's blood glucose in a given day is within the permissible range, generally between 70 to 180. So in other words, to reduce your risk of extreme blood glucose levels of less than 70 or more than 250 or 300. So the goal of therapy is not just to reduce the HbA1c, but also to increase our TIR, or the time in range, and to reduce the TBR, which is the time below range, and the time TAR, which is the time above range. So the goal is generally to keep the TIR more than 70 to 75%, right? So that's within the permissible range. Why is that important? Because we know that the TIR, or keeping the blood glucose within the permissible range, or in other words, reducing glycemic variability, is key to reducing the risk of complications in our patients. So this is data to show us that when we maintain a person's blood glucose within the permissible range, there is a reduction in the risk of both micro as well as macrovascular complications. So that, briefly as an introduction, we now know that sensor-based blood glucose monitoring can improve outcomes in our patients, and increasing time in range, like I said, reduces the risk of complications, improves quality of life, reduces the risk of hypoglycemia. Ultimately, we're also going to end up with reducing hospitalizations and, of course, reducing HbA1c. And the current options for CGM that we have are, of course, we have the Abbott Freestyle Libre, which is the most commonly and widely used tool. We have the Dexcom, which we don't have here available as yet. We have the Guardian Connect, which is from Medtronics, and the Eversense, which is also tool, not available in our part of the world as yet. But now coming to the crux of the matter, what I'm actually supposed to be discussing is the limitations or challenges or barriers to CGM use, right? And I divided it over here to two scenarios: the patient barriers and the clinician's barriers, right? So the patient barriers would be most commonly would be the cost. I think that's one of the major concerns that most patients have. And then the clinician's barriers would be concerns about the accuracy, the technology, being not well trained with reading a CGM report. But I'm going to run us through these in a little more detail. So the first most important would be the concerns about accuracy, right, and reliability of the data. And for obvious reasons, because we have to keep in mind always and also explain to our patients that this is not a blood glucose measurement, but it is an interstitial fluid that is actually being measured, the glucose from the interstitial fluid, right? Because the CGM remains on the skin level. Um, Also, there is a lag between the blood glucose and your CGM blood glucose, and there are certain. This is interesting that certain substances, which of course this is from the paper that I picked up. It's from Anhalt and the publication 2016. But they have actually found that certain substances, like even something as simple as paracetamol, can interfere with the interstitial glucose and can give false readings. Physical factors would include, of course, when patients tend to pick on it, or if they lie on that side and if it gets displaced, then you can have false values. There's also something called compression hypoglycemia, where if the technique of insertion of the device or the sensor is not done properly, it can compress the skin and give you false hypoglycemia reports. So I just put in a case study here. This is just last week that I saw this type 1 lady was a 37-year-old, and she came in. She had just delivered her baby recently, so her HbA1c was maintained very well through the pregnancy. She's been type 1 diabetic from a very young age, and now she's 35, 37. And So she came for her review. And this was her CGM report. The HbA1c, of course, this is just a calculated HbA1c over the 15-day period or the 14-day period, which showed 4.4. And all these episodes of hypoglycemia which were happening, so you can see that and almost at the same time every day. And she said, doctor, the CGM kept showing that it's going very low, but actually it was not low, so I don't understand what's happening. And the lab value, for that matter, showed us a HbA1c of 8.1, and her fasting was 111, well under control in fasting and postprandial. HbA1c is not so low, but what I'm trying to say is the patient had no symptoms of hypoglycemia, and her fasting postprandial were not within the range that you're seeing here in the CGM. So this is pretty common. There is a mismatch between the blood and your CGM values, lab and the CGM values. So the recommendation is that generally, I think this is something we all follow. We do need to tell our patients, educate them about the importance of blood glucose testing. And always, when the CGM is showing a value of less than 80 or more than 300, so any extremes of blood glucose, or if the patient is planning to take any action, for example, if they suspect a hypoglycemia, if they have symptoms of hypoglycemia, it's always best to check the blood glucose or confirm it with an SMBG or with a capillary blood glucose testing. Hemodynamic instability is a condition where we always recommend that CGM may not be reliable, and immediate postoperative state as well. This is a publication in which they found Asian data in which they found that there are high discontinuation rates. Around 50% of 40 to 50% of patients discontinue their CGM, and for various reasons. Many of them are not happy wearing a device there or a sensor there. They have difficulty inserting it, experience that there's a failure, various technical issues, and concerns about accuracy was also one of the reasons. Another factor that we sometimes tend to overlook as clinicians is from the patient's point of view. Not just the patient's, even the attender's point of view, it can be very overwhelming, right? When we put a patient on a CGM, it of course it also depends on the patient's predicament or the patient's personality, but I'm sure many of us senior doctors here as well would have come across patients in whom they become very anxious, and it becomes like an obsession. So sometimes the wife comes back with the husband who's a patient and says, doctor, please remove that thing, he's obsessed, jo bhi khana dete hain, he says, no, no, now my sugar is so much, I won't eat. So they become a little sort of obsessed with their blood glucose. It can be an advantage because it gives them a lot of insight, a lot of information, and makes them aware of which food item. So it depends on how the patient handles it. But in some cases, yes, it can be a little overwhelming and can add to the patient's anxiety and interfere with their quality of life. Nevertheless, it is very, very empowering and a useful tool for patients, however. Last but not the least, lack of reimbursement. Many of the do not cover CGM, and this becomes a barrier because cost is a concern for many of our patients, and this is a limitation as well. So, what would be the strategies to overcome these limitations? Now that we've discussed the limitations, would be, of course, patient education, tailor make programs and educate patients on what to expect from the CGM. I think I most commonly I make it a point to tell patients that this is not a blood glucose that we are checking, it is interstitial glucose, and so there is a permissible range of accuracy or inaccuracy rather to expect. And so like I had mentioned earlier, if there are extremes of blood glucose like less than 80, more than 300, we tell the patients it's always best to tell them to check their blood glucose reading, confirm it with an SMBG or a capillary blood glucose reading, and training of not just the patient, or training of not just education of patients, but also training of healthcare providers, HCPs. Also, we need to also be equipped with reading CGM and awareness about time and range in the spectrum of diabetes management. So, in conclusion, although of course we've discussed the limitations of CGM, I think we have to accept that CGM has, in fact, been an empowering tool, a very powerful tool for both clinicians as well as patients. It has given us a lot more information for us to tailor make our prescriptions, to reduce the risk of hypoglycemia, to detect situations of nocturnal hypoglycemia or hypoglycemia unawareness in patients who have very brittle diabetes, especially type 1 diabetes. Has become, for so many parents, mothers of children with type 1, it's become such a useful tool because their frequency of pricking the child has come down. So it is a very, very useful tool. Nevertheless, there are certain limitations which we've discussed here today, and we've also discussed the strategies to overcome that. Most common limitations being concerns about accuracy and cost, and the fact that it is not reimbursed by most of the insurance policies. Thank you.